But what about, the back of the eye? Well, retina is a very special subspecialty within eyes because the diseases we treat are common, like age-related macular degeneration while you're here. We also take care of patients with diabetes mellitus and diabetic retinopathy. But we're focused not only just on providing the best care for the patients, we're focused on finding out what our best next treatments are, since the bar can always be raised higher for any disease, even these common diseases. The transformation in wet macular degeneration that you heard about earlier today has been truly remarkable. I mean, patients now can actually see their grandchildren, drive a car, watch TV. I mean, this is what you want to do. But to digress a little bit, I think what Dr. Gupta and January Higgins, if she'd stand up for a second, I think she deserves a shout out. There she is. What we've recognized is not only their unmet medical needs, but their unmet community needs, and we can do better. And that's, I think, Dr. Gupta and January deserve a little round of applause for recognizing that the community needs more education, and we look forward to engaging you with future seminars, meetings, parties over time, right? So thank you very much. So I don't want to say too much other than at Will's Eye, Mid-Atlantic Retina, we're focused on you. And I was thinking about this from the patient's perspective. What does our mission statement mean to you? Our mission statement is to take the best care of who's ever sitting in front of us right there in the room, in the office, in that chair. That's number one, above all. Number two is we're really interested in finding out what the next best treatment is, not just what's good today, but establishing what's better for tomorrow. And many of our patients engage in our clinical trials, which is really a privilege as far as I'm concerned, an honor for us to have them enter it, because sometimes they say, well, we don't know if this intervention is going to work, but they'll say, well, if not for me, maybe for my children. It's that kind of, it's like duty and honor, if you will, that is so impressive to me amongst our patients. We're involved in clinical research, not only to take care of you today, but to figure out what's good for you tomorrow and for your children down the line. I think that's really different than what you get in a lot of other practices around the country. We're involved. Number three is, in our mission statement, and I think this is really our secret weapon, we are highly involved in training people that are going to take care of you in the future, the next generation of doctors. And I'll brag a little bit. I mean, Rick is in charge of the fellowship program with Dr. Sibalingam, but we get the best gentlemen and women to come to our program. Why? Because we're very busy, because we're interested in taking good care of patients, and because we do a lot of cutting-edge research. These trainees or fellows that we work with are superhuman beings. They're compassionate doctors. They're so talented. I can't tell you how funny, how talented, how interesting our fellows are. It's a real privilege. And the secret weapon for you, from the patient's perspective, is that you get to see them as well, whether it's an emergency on a weekend, like me in the operating room today. That's why I'm dressed this way. It's not to call out any attention. But it's really a pleasure and something that benefits our patients as well. So this is what we do, and I think this is what it means for you from a patient standpoint when you're in our practice. There are a lot of partners that we work with. I have to, of course, acknowledge all our staff that are here, but also supporters who we work with to figure out what's good, and these are industry partners. So just a few here. The 4C group, right over there, you want to raise your hand. That's a home monitoring system. The Focus and PRN groups, which look at nutritional supplementation for age-related macular degeneration. Take your vitamins, eat your colors, eat fish like tuna and salmon. The reason why omega-3s are good is because the omega-3 component, DHA, makes up about 50% of the matter of your vision cells. Those lipid membranes are what compose the vision cells in your eye and also make up a majority of what your brain is composed of. That's why omega-3s, I think, are still interesting despite one study that's at a lower dose that showed no real effects. We have another supporter, low vision services from Wills. You know, as we all get older, we evolve. You can't run anymore, you do yoga. You can't read the New York Times, you get a Kindle. You know, we evolve. And the low vision people here at Wills have tremendous experience in helping people evolve to get around any visual challenges. You know, it's not a miracle. I mean, there's no magic telescope, there's no magic implant, but they're very, very experienced, very compassionate, very good with that particular service. So thank you for supporting us. I don't really have anything else to say. I know we're going to have questions and answers because you may have some, so we'll open it up to questions. Any questions? Yes.
Don't wear glasses and they're in their 30s and late 20s, should they be going yearly and saying you have a parent that is at risk or does have the early stages?
Okay, so I'll repeat the question and then it's a great question, then I'll let my partner experts answer. The question was, I have macular degeneration. What should we do about my kids? Should they be examined? Should they be taking vitamins? What do you think, Alan Chen?
I think that in general, if you have a family history, especially we know family history is very important in this condition, the general regular eye examination is a good idea. I would say to my patients above age 30, if you've never seen an eye doctor before, it's a good idea to go and get examined if your mom or dad has AMD. Now, this doesn't mean necessarily they're going to be going every year, but I think if they've never had an exam before, it's a good idea.
But if you do not have it, but you are at risk, should you still follow that?
If your child,
for instance,
okay.
I'm at a higher risk. I was just seeing my Dr. McGuire, and I'm taking the vitamins, I'm doing what I'm supposed to be doing, but now there is no family history of it. Your parent remains. So now my adult children, at what age should these children?
That's a great question. I mean, partners can chime in, but I think I usually tell my patients this is an evolving area too in terms of screening guidelines, and we're looking at the genetics and looking at these things to create better screening guidelines for families and patients. If you yourself don't have it but are at risk, that I think it's less of a powerful push for having your children also be screened at this time. But in general, though, I think, especially for patients above age 30 who've never had an eye exam, I usually tell them to have a general baseline exam. Certainly, it's good for screening for other conditions as well, not just for retinal problems.
I think, a good rule of thumb. I mean, if you have signs, even early signs of macular degeneration, if you're worried about your children also developing that, I mean, keep in mind sort of the statistics that we went over. I mean, generally patients that are under the age of 60 are not going to have significant enough macular degeneration, and we're not really going to treat those patients so much. I think 30 is a reasonable time period to start getting exams, but certainly by the time they're 50, get a good dilated eye exam with a good ophthalmologist or optometrist to really take a look at the retina and see if there's any signs. And if there are, then more regular visits should be indicated at that point.
I do just have one other question.
Sure.
I have a cataract. It's probably 85% causing my discomfort and my slight blurred vision. Is that better to be taken out now before I get it, if I do get it?
The question is...
And if you have a very conservative ophthalmologist,
right.
how do you deal with it?
Question is, I have an evolving cataract. Turns out, unless you've had cataract surgery, we all have evolving cataracts. So there's kind of an art to this, and that is, it depends on the patient and it depends on the surgeon. To what extent does it that are not surmountable with glasses, for example. I can't read. Well, when I put my glasses on, I can read fine. That would suggest that cataract surgery is not indicated. Well, I can watch the movie, I can drive my car. It's getting a little bit blurrier, but I can get by. In general, I mean, my partners are pretty conservative, as we are. I mean, cataract surgery is the most successful surgery in medicine. And yet, it still has success, meaning efficacy and safety. It's pretty safe, but you can still have a problem with any surgery. So unless you need something, we're generally advocating hold back.
But can you have it taken out if you do develop the wet type?
You can have cataract surgery regardless of your retinal conditions. Yeah.
I just want to make one quick comment about that. You know, I see a lot of patients that come in and they've been told they had cataract, they've been told they had some macular degeneration. And one fear that I always have is that there are some patients that chalk up their blurred vision to cataracts and don't get seen when they start noticing things getting worse, just thinking, oh, it's cataract, my doctor said, you know, I can get that done whenever. But if you do notice that the change in vision, it's really important to get in because, you know, not uncommonly, at least in our practice, we see patients that thought it was cataract, waited 6 months, and by then they had a big scar in their retina from wet macular degeneration. So just get it checked out.
Slow gradual is cataract history. Unless it's traumatic, it's rarely abrupt. And it's not associated with distortion, so straight lines don't look crooked or curved, or you should have
That's a good
dark
point.
central area. Cataract creates diffuse haze, not just square in the middle. So the symptoms are different, but they're usually like watching paint dry. It's like the aging process itself is just slow and gradual.
Another question.
Cataract surgery. My wife developed lung cancer. They were kind of watching her cataracts, and she hadn't gotten to the point where the doctor felt it should come up. However, she got to the point with the lung cancer where she couldn't have cataract surgery. She spent a year not able to read and not able to watch television and enjoyment. So I told my doctor, hey, if someone's showing up and saying, hey, I've got lung cancer, I have some other condition that's developing that would prevent cataract surgery, and they're going to be stuck,
Right.
unable to see for, you know, a relatively extended period of time, I think it ought to be brought up and said, hey, maybe we should get that cataract taken care of now.
Can I repeat your comment just so everyone can hear? If I could translate, my wife had another medical problem, a serious medical problem, which then put her visual challenges as secondary, namely her cataract surgery. But she spent a year getting treated for lung cancer, not being able to see as well as she would have liked to. I wish they would have taken care of her eyes concurrently with her other medical problem. And I you know, we're lucky. People value vision, and that's why what we do is pretty meaningful. So I agree. There's a question right there.
I had cataract surgery. I'm 95 years old.
You look great.
Wet macular for almost 6 years now, being treated very successfully by Dr. Shu. It's absolutely the most wonderful thing that ever happened to anybody with this condition. And my cataracts got so bad, I just had an operation in June, beginning of June, on my cataract because it was that difficult with all the fuzziness. And it's coming along fine, and I have to have the other one done soon. But I've had it done, and I would have had it done earlier if I knew that I needed it.
The comment is she had successful improvement in vision with cataract surgery even after she was being treated for wet AMD, and you can have two problems and two solutions that are not really related, but that can help you, so that's great.
And I get the injections, and they're wonderful.
Right. Is that Dr. Shu? Really? You sure? It's right? You didn't try Chang or Gupta. Yeah.
Can you comment on the incidence of corneal abrasion during the injection procedure? Obviously, we're asking because we've had this experience, but in choices of anesthesia, for instance, is one more granular than another? Does it leave something that's sandy in the...
Me?
Well,
In 2 out of the last 3 injections, he's experienced corneal abrasion immediately.
yeah, in the studies, the question was, is corneal abrasion common after injections? And the symptoms of corneal abrasion, it feels like there's a stone in your eye or sand in your eye or tearing and some swelling. It's not dangerous, but it heals rapidly. But it's
Infection.
But it's very uncomfortable. Infection risk is very, very small with corneal abrasion. You know, a lot of people had just something fly in your eye. We probably all experience some symptoms of them. But the injections in and of themselves don't cause corneal abrasion. But of course, we don't want you to feel the injection, so we numb the eye. And the eye will typically be numb for at least an hour afterwards. And so when you're numb, a couple of things happen. You don't feel like you have to blink. And when you don't blink, the eye surface dries out. And when the eye surface dries out, the surface skin or epithelium, just like if you have chapped lips or dry skin, will flake. And since there's a lot of nerves right under that epithelium, when that slips off, you feel it. Corneal abrasions are very uncomfortable. So lots of times it's related to the numbing process and being numb afterwards. So I always tell people, listen, I can put some ointment in, and sometimes we'll do that for people who have recurrent corneal abrasions. Or 2, don't rub for the first hour and really concentrate on blinking, because you'll see people just stare because they don't feel the need to blink because they're numb. And that's the most common reason. But in the big studies, the incidence of corneal abrasions was somewhere, up around 5% or some subconjunctival hemorrhages. When we give the injections, you'll have a patch of redness as well. It's kind of like a bruise. So there are some people who are more prone to corneal abrasions, like diabetics, okay, or people have other reasons for numbness of their cornea, chronic use of topical medicines sometimes will cause that as well. Contact lens wear during their lifetime can also cause corneal anesthesia. You can even have other things like brain tumors that can cause that. But the most common reason by far is the numbing process itself related to the injection.
I'll make a suggestion. Let your doctor know that you've had a corneal scratch after an injection the last couple times, and ask them to put in ointment and maybe just patch your eye until dinner that evening, and that may help. Hopefully that'll help.
Can normal ophthalmologists treat AMD, or can you describe the difference in training between a retinal specialist and a regular eye doctor?
Sonia, you want to take that one?
Yeah, sure. So for
Loudly.
Sure. Yeah. So general ophthalmologist does internship, residency in ophthalmology, and they're trained in all eye diseases. A retina specialist.
Sorry, I can't hear you.
I'm sorry. A retina specialist does internship, residency training in ophthalmology. So they're trained in all eye diseases, and then they do 2 additional years in subspecialization for the retina and surgical conditions of the retina. So their area of focus and expertise is retinal care. And all of us sitting here are retina fellowship trained retina surgeons. So the difference is the level of experience and volume with treatments specifically focused on the retina.
To answer your question another way, yes, ophthalmologists, other eye care providers can diagnose age-related macular degeneration. If you need treatment, I mean, I'd go to one of these.
I don't have a debate that, right? I think you guys are the specialists, you're the experts here. But the point being is if a patient unknown, right, goes in,
Right.
mom, for instance, goes in to see the regular eye doctor, would they try to treat that, or are they attuned to retinal specialists to refer that patient then to a facility like yours?
Around here, yes. You go to the middle of Wyoming, probably not. So the question was, will people send you to the specialist that you need? The answer is most of the time around here, we're a lot of retina specialists around the corner, like we are. We have 13 offices from the shore to Delaware up to the Poconos.
How many retina specialists are there across the country?
There are about 1,500 U.S. retina specialists. Maybe that may over 1,000 to 1,500.
And compared to ophthalmologists, how many ophthalmologists?
About 20,000.
Okay. So less than 1%.
We're special.
Right.
comparison would be, you know, if you have an orthopedic problem or a bone problem, you may see a general orthopedic doctor for like a hip or a knee or a back. But if you have something a little bit more severe, you know, you may see a spine specialist or a knee specialist or a hip specialist that only does hips and only does knees and only does spine. And so that there is probably some value, some subtleties in care, some subtleties in detection that specialist may be able to obtain that a general orthopedic doctor may not be able to. So it's a great question, and there's no real, you know, black and white area. There's a lot of gray.
Ladies first.
I have a question about eating fish, especially like salmon. Does it matter if the salmon, if you purchase salmon that's farm raised as opposed to
I love that. I love this question. May I repeat it? Okay, salmon. Does it make a difference? Farm raised or wild salmon? I have an opinion. I have an opinion. You're shaking your head no. I would disagree with my partner.
No, well, the price is double. No, seriously, the price for wild is doubled at a farm. So I would say some farm is better than none. And you know, I didn't get to that part of the talk, but our Western diet is terrible. It's the omega-3 and omega-6 balance, and just omega-3, I mean omegas overall is so low in our diets, but especially the omega-3s being lower, there's people and experts looking at that's driving a lot of the issue. If you look at other diets, Mediterranean, Asian diets, there's a better balance, and we see less heart disease in certain conditions, and cognitive aging decline, and those sorts of things. So I think bottom line is I'd rather my patients eat farm than nothing, but I think if you have the extra money to make that difference, I mean, there's some benefits outside of what we've talked about here, perhaps, to have a wild salmon as opposed to farm. But that gets to the areas that maybe you could comment on. But bottom line, I'd rather my patients just eat fish, you know, occasionally, a couple times a week as opposed to not.
Well, I think my concern was like, you know, I know that they sometimes use antibiotics and things like that when they have farm raised, and then of course there's various chemicals and things in the ocean that shouldn't be there. So, you know, is there higher mercury in one than the other, or you know, does that matter?
Differences in exposure between farm versus wild. So let me try and address a couple of things, at least from my own opinion. I completely agree with my partner. Some cold water fish, like salmon, tuna, mackerel, sardines even, but they're too salty for it to be good for us, are good. Why cold water fish? Because they're the ones that are enriched with omega-3s. The good oil, the good omega, the good essential fatty acid, the one that comprises a lot of your vision cells and of your brain. The primary producer of omega-3s is actually algae. Algae is abundant in the ocean, and therefore, and in waters. And therefore, I think wild has a theoretical benefit because the salmon or the tuna consume algae that they ingest and put into themselves, which we then ingest. And the farm-raised have less primary produced omega-3. They're actually fed some carbohydrate diet. It's kind of like what we do in this country. We eat a lot of carbohydrates that are processed, and that's why when I talk to my patients all day long, I'm telling them, eat less white food, less white bread, white pizza, white pasta, eat less. And anyway, coming back to your fish question, the farm-raised probably don't have as much exposure to the primary producers of omega-3. So eat some fish, but I'd rather you eat wild. But if you can't eat wild, then get salmon from any source. And in terms of mercury exposure, it's not really an issue in salmon. But in tuna, if you eat a lot of tuna because they're kind of higher on the food chain, then you can accumulate mercury in those large tuna, and then we eat tuna every day. I mean, I eat a lot of tuna, and my doctor said, you probably should get a mercury level. I said, okay. You know what the expression is for mercury toxicity? Mad as a hatter. So Sometimes I get angry in the office, do you think? Maybe I can blame the fish. But that's how I would answer that question. Yeah.
Farm fish also are in a confined space and they swim around in their own feces.
There are, I would check with the source. There are increasingly, my father's really into farm fishing, but there's increasingly
Better farms?
yeah, there's different better farms which are actually in the open sea, and they have a lot of different methods of trying to get around some of those things you brought up. So check with the source. Not all farms are the same.
But it's hard to tell where it came from.
Yeah, if it's a good food vendor like some of the fish markets in the city or outside the city even, they know where their fish farms are coming, what kind of fish farms are coming from.
Dr. Ho had to head back to the hospital. What other